Hi, my name is Karen Marshon Singleton, and my presentation tonight is on end-of-life care, America's untapped resource. It is my belief that end-of-life care in America is an area of healthcare that is largely untapped and grossly underutilized. I'd like to discuss briefly what end-of-life care involves and some observations as to why it is underutilized in America today. Excuse me. As a healthcare professional, I've seen firsthand situations where life-saving measures were utilized in situations where the outcomes were marginal at best. My research suggests that the use of healthcare dollars could be better utilized by making patients comfortable when they are facing life-limiting illnesses rather than promoting cures with probable minimal success. End-of-life care is the transitional period between the diagnosis of a terminal illness and the actual death of a patient. Death, as we know, is an inevitable part of life. Sometimes it comes sooner through unexpected situations or circumstances, but for those for whom it doesn't, the dying process requires stages of grief and preparations that must be made. There's also the patient's physical condition and comfort to consider. The hospice philosophy considers the patient and the family from several aspects. The patient's physical well-being is primary, that of he and his family. Is he in pain? What methods can be used to alleviate the pain? Is there spiritual or emotional distress? Are there financial concerns that need to be considered? Hospice utilizes a multidisciplinary team approach to look at and offer assistance to patients and their families during this most difficult period. Title 18, Section 1861 DD of the Social Security Act describes conditions for which hospice care may be appropriate. My visual aid is a graph which shows diagnoses for which hospice care may be appropriate. This includes cancer, heart disease, dementia, debility, lung disease, kidney disease, and there are other illnesses. Hospice care in America began in the 1970s. Statistical data from the Centers for Medicaid and Medicare Services show that in the early 1980s there were 31 recognized hospices, and that number by 2007 has grown to over 3,000 recognized hospices. Medicare spends over $300 billion per year for healthcare. Of that, almost 40% goes for inpatient care. In 2006, less than 3% of all Medicare dollars were spent on hospice care. In 1992, cancer made up 75% of the diagnoses for which patients were admitted to hospice. Now that number, as we saw in the visual aid, is less than 45%. There are diagnoses, as we just discussed, as dementia, heart disease, lung disease, and other things for which a person can be admitted to hospice. Duke University provided a study which showed that patients who died under hospice care cost Medicare approximately $2,300 less than those who did not have hospice care. So it is financially and fiscally a responsible thing to do. However, it is not without its drawbacks. Many physicians are afraid to utilize hospice because they are not sure of how to utilize it. Pain management, which is a cornerstone of hospice care, has been one of the largest problems. Physicians are often afraid to medicate patients appropriately because of fear of prosecution for overprescribing pain medicines. Thus, inadequate pain management has been identified by healthcare experts as an issue that plagues palliative care providers. Another issue which causes problems is constant turnover among hospice employees. Hospice paraprofessionals have been found to be highly underpaid. The U.S. Census documentation shows that nearly 20% of hospice or home care paraprofessionals live on the poverty line. These low wages, of course, equate to high turnover rates among employees, and so retention of quality employees is severely impacted. Having a terminal illness is devastating enough. Having the resources to cope with such a life-altering illness can make all the difference. Hospice is an option that is open to most Americans, but is used by a very small portion of the population. In closing, American healthcare is in a state of crisis, and exploration of cost-saving strategies is imperative. Hospice could be an option that could help reduce healthcare costs at the end of life. There are several questions that have been asked in regards to my presentation. The first question was, if hospice is such a great thing, why aren't more physicians encouraging patients to use it? My response to that is, there are several reasons. First is that end-of-life issues are extremely personal. It's very hard for a physician to encourage a patient to stop pursuing curative measures when the physician looks at his or her own mortality and/or religious beliefs. Secondly, it is difficult to have a discussion about such a sensitive issue where you must really know your patient and their family and be willing to certify that this person could very well die within 6 months. Another question that has been raised is, what gives the hospice team the right to make the decision that someone's life will end in 6 months? They don't have any rights to make the decisions. They use educated guesses. If a person has a cancer and the person is otherwise healthy, the cancer is more likely to respond to measures such as chemotherapy, radiation, or surgery. Removal of the cancer usually has very good outcomes. When, however, it is a recurrent cancer or an elderly patient with multiple comorbidities, the chances of the cancer responding to curative treatments becomes diminished. The patient may not die within 6 months and can thus be assisted through hospice care to have a comfortable end of life. Last question that was asked was, is the hospice philosophy about quality of life versus quantity of life? My answer is absolutely. Pain management, comfort care, and support for the patient and the family are the cornerstones on which hospice care is built. Thank you for allowing me to provide this information.